I just want to ask one clarification, others there. When you say the stroke issue there, I just want clarification. I think any embolic phenomenon will come through that, not necessarily just the cerebrovascular, but any sort of embolic phenomenon.
Sure.
There, right?
Should we, as emergency physicians, be looking into dabigatran more? Is this primed to replace Coumadin? Is this something that we need to start being more comfortable possibly prescribing?
I think so, barring the financial concerns there and everything. I think it has been. I think it has been in the mainstream now, at least there. But there are a lot of other drugs coming out there in the European Society and everything they were talking about there too. There are a lot more newer direct thrombin inhibitors, the DTIs, the oral DTIs are coming over there, and hopefully they will pan out to be. But I think dabigatran is ready for prime time in a way.
I think for a emergency department, it's a great drug. I think the cost issues will also, they outweigh the advantage, or I mean, they have more advantage because Coumadin, if you start somebody, they're not going to be therapeutic INR for God knows how many days. And my fear always, and you have the fear more, but I see some patients who I want to start on anticoagulation, and I'm not sure they're ever going to come back and see me. But I'm responsible because I've started the Coumadin. Now, if they don't get an INR or they don't get some testing done, I don't know where the Coumadin levels are, but I am medical legally responsible for that. Now, that takes it away when I put them on dabigatran. The problem with Coumadin is you have to put them not only Coumadin, you have to give them Lovenox, you have to give them shots, you have to be sure that they are able to take the Lovenox and Coumadin, where are they going to get the blood test, who are they going to follow up with. You start Pradaxa or dabigatran, it acts as fast as Lovenox. In 2 hours, it's effective. It's a short-acting drug. Twice a day you have to take it, no interactions, no fluctuations, and the patient can go home sooner, rather than, and even cost-wise, if you add Lovenox, and I'm talking cost-wise only for the hospital and ED, if you add Lovenox and Coumadin, it's more expensive than dabigatran itself. And now, even in the outpatient setting, dabigatrans are, it's becoming cheaper, and most of them can afford it to $55 with co-pays.
Well, the last quick topic, we're just going to have a brief thing on A-flutter. A-flutter is that organized rhythm, A-fib is the disorganized. Should we be leaving A-flutter patients in A-flutter and just sending them to the EP lab?
100%. And I'm biased about that. I won't say EP lab, but, to see an EP guy. And I'll tell you why, and I may be biased, and I'll ask Suren for his opinion, is because we are trying to cure AFib with ablations, but I think realistically we are still far away. At the best, AFib ablation is a better tool than the best antiarrhythmic medications we have for rhythm control. But for atrial flutter, it is curative.
Right.
It is 95% curative. And I do not hesitate, not just because I want to do a procedure, but I do not hesitate to take any patient to the EP lab for a flutter ablation because anticoagulation issues, 4 weeks later, they can be stopped, provided they are the typical flutter, which the majority are. Anticoagulation issues are gone. Rate control issues are gone. Rhythm control issues are gone. After 4 weeks, they could be without any medicines for this perspective. And now with the newer equipments and things we have, risk of recurrence is less than 5%. And I mean, I'll tell you a story that, not a story, but a patient, I even dared to take a 90-year-old with a platelet count of 38,000 to do a flutter ablation because then, otherwise I'm stuck with giving him Coumadin or Pradaxa for the rest of his life. And 90-year-old, you don't want to give it anyhow. And he's a functional guy, and he's going to drop and break a bone or hurt himself.
Sure.
So flutter, ablation.
Do you want a phone call 3 a.m. on a patient in A-flutter, systolic blood pressure at 80? Is that worth saying, listen, he's in flutter, can we get him into the EP lab tonight?
No. Okay, so I'll come back to that. Well, as things are changing, we might be doing that. But the beauty about flutter ablation is you don't have to be in flutter when you're doing an ablation.
Okay.
So you could, if needed, you could cardiovert them,
Okay.
or you could leave them in rate control. It is not something that you have to do now. Most of the times when we do a flutter ablation, we do a TE in the lab itself to make sure there are no clots and then proceed with it. We could still do a flutter ablation in sinus rhythm and achieve the same endpoint, same success as it would be if you were in a flutter.
So it really doesn't, leaving them in a flutter or getting them out of it, that
No.
doesn't matter. You'll be able to find the pathologic track and ablate it.
Right.
Well, thank you very much. There's going to be more. We're going to go through we're just going to talk on it'll be on the show notes on the web for just some different medication management principles and some other medication stuff that we didn't have time for. But thank you very much, Dr. Bond, Dr. Avula, and
Thank you much.